Ladies and gentlemen, we're going to try and stay on time. We're running about 1.5 minutes late, but I'm sure you don't object to that, because what we're about to hear is an incredible overview of a really important area. Allow me to introduce Liz Perkins, who's behind me, who's come from Liverpool. She's the William Rathbone the Sixth Chair of Community Health Services in Liverpool. And I remember some time ago with Medical Pilgrims, we visited Liverpool, and they told us the history of the public health in Liverpool back in the 17th, 18th and 19th century. And I can tell you that city really is the heart of public health. And it really was where public health in England started, even though sometimes John Snow is given that accolade with his discovery of typhoid. But it was really in Liverpool where it all began, with the terrible poverty and all the other things that were happening. Particularly there, it was the typhoid as well, which caused the problem, in 1836. But Liz is not going to talk about typhoid. She's going to talk about some very interesting concepts around this disease area, illustrating, I think, really her experience in working with patients and groups in chronic disease. And I think we're going to learn a lot from what she's about to describe to us. So thank you so much for coming, Liz, and I'll hand the microphone over to you.
Good, well thank you very much for inviting me. I'm on somewhat strange territory because I've never been to an ME CFS conference before. I'm a social scientist, and I think that's why Stephen thought it might be useful for me to talk today, because I'm interested in the way in which patients construct narratives around their illness. And particularly in relation to ME, there's quite a very different process that goes on, partly because of the lack of a medical diagnosis. So, the talk is called In Search of a Diagnosis, What Does the Literature Tell Us About the Patient Experience? The paper was actually prompted by one of the findings in the Action for ME survey, that it can take up to 2 years for people to receive an ME diagnosis. A finding which is also supported by other research. And it got me wondering what that meant for the individuals with the condition. I wanted to know what the research literature suggested life was like for people living in this diagnostic limbo land for so long. In reviewing the literature, I make reference to the Action for ME survey conducted last year. But I also draw heavily on the work of Dr. Lisa Whitehead, who was a PhD student in our department, and her work focused on people with ME. I'm also going to draw on the work of Professor Arthur Frank, who's a sociologist working at the University of Calgary. Arthur Frank is interested in the work that stories do, particularly in the context of illness. His starting point is that for most people, most illnesses begin with the idea that getting better and recovery are possible. And he has something he calls a restitution narrative. Yesterday I was healthy, today I am sick, tomorrow I'll be healthy again. Health is defined as the normal condition within which people live. And I came across this advert, and I blanked out the producer of these cold remedies, which basically says you don't even have to wait until tomorrow to be better. If you use these drugs, you do not even have to lose a day. And that's kind of what our society expects. Ill people have to learn to think differently. But as Arthur Frank suggests, the story of illness that trumps all others in this period of history is the medical narrative. The ill person's story relies heavily on what the doctor has said. The individual becomes the patient and is defined by the illness. The diagnosis offers a sort of legitimacy to the illness. Without a diagnosis, it's difficult to become a patient. Tolcott Parsons, a sociologist writing in the 1950s, developed the sick role theory as a way of explaining the particular rights and responsibilities of those who are ill. Parsons saw the sick role as a form of deviation from society's norms and expectations. He argued that people are generally expected to be productive members of society. However, where people are unable to carry out their usual everyday activities, such as going to work or school or looking after someone, if it is through illness, then the deviance is positively sanctioned. However, in general, for the deviance to be sanctioned, a medical expert, such as a doctor, must certify that a person is actually ill, a process that legitimates their illness. Legitimisation is proof that the person is truly sick and in need of a more lenient set of expectations. This is the equivalent of a doctor's note that you take to work to prove that you didn't simply skip work to do something more enjoyable like going to the cinema. Oh, I already started and I haven't told you what the structure is. In fact, I think we've deleted oh no. Parsons describes two rights and a responsibility that an ill person has. A patient has a right not to be blamed for the illness. It's not their fault, and a right to be exempted from normal obligations. However, a patient has the responsibility to make getting well a priority and to seek and take appropriate treatment for his or her condition. These rights and responsibilities may be in effect only during a certain period while a person is ill, and so may be temporary, and the specifics of these expectations will vary depending on the seriousness of an illness and how much the condition interferes with everyday life. Parsons was writing in the 1950s, and although we're beginning to see an erosion of some of these elements of the sick role, particularly in relation to tolerance of those behaviours like smoking and obesity, which result in illness, the major elements of the sick role remain true. So this is where I tell you what the structure of my talk is. I'm going to look at the literature which relates to those areas in which doctors are not able to identify the cause of an illness, traditionally known as medically unexplained symptoms. I'm then going to go on to look at what happens to patients with undiagnosed ME, and then finally focus on the strategies people adopt to getting better. And I put strategies or living with ME because sometimes sociologists compartmentalise and package things just the way doctors do. And living with ME is probably a better explanation of what I'm going to do. So I'm going to start with medically unexplained symptoms. Not surprisingly, since diagnosis is usually the prerogative of the medical profession in this country, the literature referring to the presence of bodily symptoms in the absence of a diagnosis falls under the terms medically unexplained symptoms. The literature on medically unexplained symptoms is vast. Reading this literature, it becomes clear that medically unexplained symptoms are common and include physical symptoms such as headache, backache, pain in muscles and joints, fatigue, and numerous other symptoms. In the general population, 2/3 of men and 2/5 of women report at least one of these complaints in the previous 2 weeks. In about 25 to 50% of symptoms seen in primary care, no evidence can be found for any physical disease. In specialist care, these percentages are even higher, ranging from 30 to 70%. In some cases, these medically unexplained symptoms resolve naturally. However, there are a number of patients whose symptoms persist and who make frequent presentations to their GP. This often involves extensive investigations and referrals. Many GPs feel powerless and in some cases irritated when patients repeatedly visit their practice with these symptoms, and they often label these patients heart sink patients. It's fair to say that unexplained physical symptoms are often confusing for both doctor and patient. Patients often feel disbelieved and not taken seriously by their doctors, while doctors feel frustrated and thwarted as they run out of medical explanations and are forced to turn to other explanations, often outside their primary area of expertise and most often psychological in nature. There are many different ways of looking at medically unexplained symptoms. A systematic review of the literature conducted by a team in the Netherlands in 2010 distinguished 9 different explanatory models for medically unexplained symptoms. In addition, the literature identifies a meta-model, the cognitive behavioural model, that actually contains components of these 9 different models. I don't intend to go through these models in any detail, and I'm sure there are people in the room who know much more about them than I do. But they can be further grouped into those that have an underlying physical explanation, those that have a psychological explanation, or a combination of these two. So depending on the approach of the individual doctor and their training, and a whole host of other variables, patients may receive any one or a combination of these 9 explanatory frameworks to take account of the doctor's fundamental inability to locate any clear biological cause of pathology. In some cases, patients report a complete absence of any explanatory framework. Interestingly, the authors of this systematic review, drawing on another study, suggest that GPs build their own explanatory models of medically unexplained symptoms based on their experience in daily practice. And I put the emphasis on their experiences because all of these explanations are based on the way medicine and science view the patient's body. There's very little literature on how the patient defines their illness experience, and this is even more the case in relation to the experiences of patients with ME. It's important to remember that medicine and science evolve and explanations are disproved and proved in a forward cyclical movement. For instance, there are many theories about the cause of multiple sclerosis, some old, some new. Old theories implicate genes and viruses, and newer theories suggest a role for bacteria, vitamin deficiencies, oil deficiencies, poisons, and reactions to vaccines, especially hepatitis B and influenza. But the only theory that has been absolutely abandoned is the 19th century psychiatric theory about hysterical paralysis, in which the sufferer, usually characterised as female, produces physical symptoms as an unconscious and sometimes conscious attempt to resolve a painful psychological conflict. It was believed that this was the cause of MS. Theories have to be revised in the light of new evidence. This is a situation which is highly relevant to understanding ME. Research on medically unexplained symptoms has not surprisingly adopted a problem-oriented medical perspective, with the patient's perspective often sidelined. The failure to understand the root causes of medically unexplained symptoms has not prevented the medical model from capturing and packaging it from a medical perspective. And yet bodily symptoms, albeit with unknown physical pathology and without a diagnosis, exert a great impact on patient functioning, often with huge negative impact on their quality of life. So at the heart of this paper is a desire to understand how patients make sense of this ME experience, given that initially they cannot occupy the medically legitimated world of patienthood. From a conceptual analysis by Jorgensen, chronic fatigue can be understood as fatigue of at least 6 months' duration that's not amenable to rest or sleep and has no relation to previous activity. It's a whole body sensation with a major impact on multiple areas of quality of life, including physical, cognitive, affective and social domains. And you're all more familiar with these definitions than me. The legitimacy of chronic fatigue as a symptom has been questioned when no physical disease can be found within the person. Although in specialist centres, chronic fatigue is viewed as a distinct syndrome in itself, elsewhere in everyday general practice and the acute sector, it still remains a contested diagnosis within the medical model of illness. From an individual's perspective, uncovering a means of interpreting illness enables a person to re-establish the relationship between the self, the body, and the world. From the restitution narrative identified by Frank, which I referred to earlier, suggesting that most people operate with a default of health and recovery as an implicit component of illness, it's not surprising that diagnosis is important. In chronic fatigue, the sudden and debilitating nature of the condition leads patients into the doctor's surgery with a desire for diagnosis. The importance of gaining a diagnosis in this and in many other conditions is well known. In Lisa Whitehead's work, the acute phase of the ME chronic fatigue syndrome experience was characterised by total disablement, typically lasting between 2 weeks and 3 months. During this phase, all participants reported loss. People were thrown from a world defined by activity to a period of complete immobility, often becoming house or bedbound. In the early stage of the condition, when the majority of people believed they were experiencing a bad bout of flu, hopes of recovery were strong. Rest and time off work were the most common strategies supported by GPs and adopted by patients. However, as it became clear that symptoms did not follow the usual pattern for flu, both the patient and the GP adopted different frameworks by way of explanation. GPs intensified their testing, but after a couple of months in which a physical basis for the illness had failed to be identified using those tests, GPs moved from physical explanations to psychological. And I've got 4 consultations here. You'll notice they don't have a time frame, and that's because GP-patient interactions operate on different timescales, so the timescale would depend on the context. So this is somebody who comes to the doctor's surgery. I don't know whether can you actually read that at the back? No. Basically, the woman says, "I feel so tired, doctor. It's not." I can't read it. It's not like me. I usually have so much energy. And the doctor says, "It's probably just flu. Get some rest and take some time off work." And the doctor's thinking, it's probably just flu. So that's the first consultation. However, the second consultation, which could be as little as 2 weeks, or it could be as much as a month or 6 weeks, the patient returns and she says, "I still feel so tired, doctor. I can barely get out of the house." And he says, "We'll order some tests. You may be a bit run down." And he's thinking, she should be getting better by now. I wonder if something else is going on. Third consultation, it's just not getting better. I don't know what to do. And the doctor says, "Well, the tests have all come back negative. Are you worried about anything at work or at home?" And the doctor's thinking, I wonder whether something is going on in her life. By the fourth consultation, it changes a bit. The doctor's thinking, oh no, it's her again. This is the heart sink moment. Meanwhile, the patient's still saying, it's not getting better, I don't know what to do. And the doctor's saying, well, the tests have all come back negative. And I'm sure many people in this room recognise this. One of Lisa Whitehead's respondents, who was bedbound, reported seeing a form completed by her GP for the equivalent of the benefits agency, which stated there was nothing wrong with her. And if she couldn't walk, it was purely psychological, because she actually had no difficulty walking. As patients' symptoms remain free of a diagnosis and the interactions with GPs become more negative, patients turn to what Frank calls chaos narratives. The chaos narrative exists where the patient is unable to interpret and make sense of the illness. In the case of ME, these narratives were characterised by the uncertainties associated with a lack of diagnosis in the context of severe and debilitating symptoms. Mary Horton-Solway uses 2 interviews with people with ME to explore how attributional stories and identity formulation are linked. In the narrative of these 2 patients with ME was constructed as a self-inflicted physical disease resulting from overwork or mismanagement. In the same way that GPs became frustrated at being able only to rule things out diagnostically, patients confused and frustrated at the absence of a medical diagnosis moved into a period of resigned acceptance and a new period of searching elsewhere for a diagnosis and treatment. Frank identifies the narratives following the chaos narratives as depicting questing. The quest narrative is about developing a new self that draws on the experience of having suffered. Lisa Whitehead's study demonstrated that a small proportion of the patients in her study were eventually diagnosed with ME by their GP. An equal number were referred to specialist services where the diagnosis of ME was given. But a large proportion of the patients in her study did not initially receive a diagnosis by a doctor. These people, who had moved out of the chaos of living with debilitating illness without an explanation, began to search for their own diagnosis. Through access to other patient stories, newspaper articles, TV programmes, etc., these patients began to match their symptoms to those of others with a diagnosis of ME. Patients arriving at their own diagnosis of ME nevertheless sought medical verification by going back to the GP with the evidence to support what they had informally diagnosed themselves in order to receive a formal diagnosis. Confirmation of the diagnosis enabled people to counter the possible accusations that they had been making the symptoms up, craving attention, or being lazy or crazy. Being given a diagnosis that confirmed that they had a physical rather than a mental condition was important. However, receiving a diagnosis did not miraculously transform the lives of these people, because there remained no definitive treatment and projections of prognosis were non-existent. This created issues regarding the treatment and recovery phases of illness. It has to be remembered that the Action for ME survey also identified that people were living with severe symptoms for an average of 2 years before the diagnosis. The diagnosis of ME allowed people to put the search for a label behind them and move on to managing the symptoms. Managing the symptoms involved searching for things that had previously been found to be helpful often to others, and this included diet, herbs, exercise, rest, and a lot of other things besides. The participants in Lisa Whitehead's study did not give up completely on returning to the person that they had once been, but they had in some senses developed a way of living with the illness. This included a restructuring of the pace and organisation of activities, resisting marginalisation from society, and finding alternative interests. None of Lisa Whitehead's participants resumed all their former activities, although other studies identify small proportions of people with ME returning to their former lives. The experience of ME, once diagnosed, was reported to be a balancing act, balancing activity and rest, and monitoring the interaction between the two in order to maximise the activities they were able to undertake within the constraints of their illness. In another study of people with ME, participants identified fatigue as primarily a physical experience, located in the body and seeing as being related to limited energy. Managing energy was described as an active endeavour where energy supplies were limited. Using more at any one point in time left less energy available for use at a later date. Individuals reported conserving energy in order to be able to have energy left to use for particular activities. Here the body was being managed so that the person did not do either too much or too little with their limited energy resource. There appears to be only a limited literature on interventions for managing energy, and so ME patients are largely left to sort out their own energy management strategies. As people moved out of the total disablement of the initial stages of ME, they lived with a constant fear of relapse, the illness casting a long shadow over their health. Having been confronted with the loss of the former self, people with ME tended to develop a new sense of the normal. A return to the self before the illness was not necessarily sought, but nor did people settle for an existence that was inferior to the one which had existed prior to the onset of the illness. Issues of identity are recognised as important to the process of living with a long-term condition. Acceptance, or coming to terms with a disorder, is often regarded as the most functional response a person can have, and we were talking a little bit about that in our workshop before this session. While acceptance in a number of studies on living with a chronic illness was the most common theme within the category of redefining self, what seemed more important for some people was the feeling that they were just like everyone else. Karen Yoshida's work, looking at the reconstruction of self and identity among adults with a traumatic spinal cord injury, argues for a pendulum model of self-reconstruction following disability, where the person's sense of self swings back and forth like a pendulum between the non-disabled and disabled aspects of the self. This is important because it's often assumed that a disability is the most important, if not the only, aspect of the construction of self or identity. Similarly, while people can and do come to terms with the changes in their life, it's perhaps more useful to view acceptance as a dynamic process, as something that comes and goes depending on context. Being less accepting of themselves and their situation at any one time perhaps does not mean that people with ME cannot move their life forward. For people who define themselves as living well in spite of chronic fatigue, the changes they negotiate in their sense of themselves are not necessarily in an upward trajectory. In Lisa Whitehead's work, the majority of participants felt that they had transcended the illness, underpinned by a deeper understanding of themselves, others, and life in general. It's true to say that, like many other people who have struggled to have their illness diagnosed and accepted by the medical profession, they became experts in understanding and managing their symptoms. I was struck when I was reading some of the literature around ME by the overwhelming desire of people who had come through the experience to provide advice to others. A simple report I came across on the web about one person's experience was accompanied by over 13 comments on the first day of posting, which escalated into the hundreds of posts from people providing advice. And this advice ranged across these, which you're clearly not going to be able to see. The first one says, anyone having CFS symptoms that came in gradually should check their dental health. My 4 months of CFS was caused by asymptomatic dead tooth with a huge cavity on its side. The second one says, the medical community has no clue on how to treat this poor man. The poor man is the person who was in the initial post. But instead they have no problem prescribing drugs that won't do anything but destroy whatever immune system he has left. When you have chronic fatigue, your immune system is super weak to begin with, and it's very easy to catch colds and other viruses. I had the flu 4 times in 2011. I at least had the intelligence not to listen to my doctor, who wanted to put me on antibiotics and depression pills. If I did that, I'd be done forever. Next one says, rest and good nutrition is all you can do, and most people will make some degree of recovery, but it takes years. Being housebound has still been better than bedbound. The next one is, has anybody here tried the ATP glutathione injections protocol? I ask because my wife has ME and fibro. Our life has gone from healthy in our 40s to a life limited to home and grocery shopping for the most part. And the final one, my diagnosis, apparently gluten and meat sensitivity, my solution, gluten-free diet and cut out meat. This is not atypical, and this is just a really random sample of the hundreds that were on this particular website. Clearly, this reflects both the uncertainties of diagnosis as well as the strategies that emerge to manage the condition. They are also important reflections on how people make sense of their condition when the medical model cannot provide answers. In the Action for ME survey, which included about 2,000 people, the most frequently self-prescribed approaches were rest, including bed rest, vitamin and mineral supplements, and dietary changes. The survey also asked participants what helped. And I'll just pull out the most interesting bits. What's interesting from this is that there were some things which were almost always helpful: rest, pacing, medication for pain, and meditation or mindfulness. While there were others, graded activity, graded exercise, and exercise on prescription, which had much more mixed responses. The NICE guidelines for ME suggest that the recommended physical rehabilitation therapies should always be delivered by a trained therapist, and it's not entirely clear from the survey findings whether the mixed response to these therapies arises from the self-prescribed way in which these therapies were adopted, or something more fundamental to the actual therapy. It's important to recognise that as people move out of the acute episode of ME, the strong desire to get better is accompanied by the quest for treatment. This quest often takes place completely outside the control of the medical model, as evidenced by the quotes that we just looked at. There were a small group of people in Lisa Whitehead's study for whom the ME experience was wholly negative. These people remained highly disabled and appeared completely unable to reinvent themselves. They continued to mourn the loss of a career they had enjoyed, and at times described feelings of worthlessness attached to their current role. The Action for ME survey reports that 2/3 of people with severe ME had been ill for 10 years or more. It would be interesting to find out whether the most negative experiences of the condition are associated with the most severe condition. The reason I question this is because of the way in which individuals begin to create a new identity within the disabled self, and I think this is an area that would be worthy of further research. There is a paucity of research on ME, particularly from the patient's perspective. While doctors have medical models of illness, patients have complex and lay models of health and disease. While research with GPs suggests that GPs think patients with medically unexplained symptoms should be managed in the community, is a recognition that they have a dearth of effective interventions for these patients. Peter Salmon at Liverpool undertook some qualitative work looking at medical explanations given to people presenting with medically unexplained symptoms in primary care, and he identified 3 types of explanation. Rejecting explanations, which were characterised by the doctor denying the reality of the patient's symptoms. Collusive explanations, in which the doctor adopted the patient's explanations for their illness. And finally, empowering explanations, and these were the most successful, in which doctors provided tangible, non-judgmental explanations which legitimised the patient's experiences and offered support and opportunities for self-management. It seems to me that the patchy nature of specialist ME services and the action for ME survey suggests that they are not all rated highly, combined with a clear role that GPs identify for themselves, highlights the need for research on how GPs can develop an empowering and supportive role for patients experiencing ME. A role which should take into account the illness narratives of people who are living with a seriously debilitating condition. Thank you for listening.
We've got a few minutes before we start the next session, so if you'd like to ask any questions, this is an opportunity to place them. Please, ma'am.
I'm actually a student at this moment, and I was recently asked to look at a paper on medically unexplained illnesses, and it was to do with referrals into outpatients. Striking thing to me was the difference in different specialties. So, for instance, the neurology, the gastroenterology had large numbers of medically unexplained patients. Dermatology had none. Now, to me, dermatology, they are focused on symptom treatment rather than a diagnosis. And I actually think that's got implications for me. That if people were looking at the symptoms and treating the symptoms rather than always looking for a diagnosis, patient outcomes would be quite a lot better than they currently are.
That's a really good point.
Yeah, well, thank you. That's a very good point you've made. Let's. Are there any other points anyone wanted to put? Liz? Well, I think so, because this is an area that none of us have really got any clear answers at the moment, and the reason we formed a collaborative in the first place is to try and seek answers. And of course, we are now beginning to think that a medical model, which you describe it, could offer us a way forward. But we've got to think of the context of all of this, and what you've helped us do today is to create a context within which our current services are being provided, which, as you described, fall a long way short, I think, for many patients in this area. But also, I think, from the medical practitioner's point of view, you mentioned general practice. I think that is one area in particular that attention needs to focus a lot more on, where we really haven't probably done as good a job as we might have done in helping general practitioners manage complicated circumstances of patients with this terrible condition, but of course the family situation that they're in as well. And I think that is something that could be done constructively. Okay, Liz. Well, thank you very much indeed for giving us your talk. We really appreciate it. So now we're moving on to the last session before we have a little break. And this session really is, I think, a very exciting session, and I'm glad Sonia's put this towards the end of the day, because this really is where I hope we're going to see some fairly high science, if you're up for it. And the reason I'm saying that is that all of the presentations you're going to hear now, and there are going to be 5 of them, we have some slight changes to them, have been funded by the Medical Research Council, either as part of the initial investment they made a few years ago to get us going in this field and helping us form the collaborative as a result of that, but also some new MRC funded studies indicating to you that fortunately good and exciting research is still being supported by this public body. So the first of these 5 we're going to hear, and the way we're going to run this is that we're going to hear all 5 of them, and then I thought, as you can see by this dining room table here, which we're going to lay up with knives and forks and food, we're going to actually have a discussion as a panel, because there may be issues that kind of cross-cut between the different ones, and you may want to hear a little bit more about them. So, if you
can we do questions after Mark's, because he's got to go?
You sure? Okay, that's fine. So Mark Edwards has very kindly has stepped in, because unfortunately Anne McCardle has had a family issue and can't be with us today, which is sad.
This is the new MRC.
No, I understand that. So Alice Russell is going to take Anne McCardle. Is that right? No. Alice Russell's taking Carmine Pariente's position, because he's got some lurgy, some virus, some illness. Anne McCardle has had a family issue, and we've got a poster out there which you'll be able to see, which does illustrate that. But Mark Edwards is a new grant that Hugh Perry brought to our attention that had been awarded by the Neuroscience and Mental Health Board of the MRC very recently. And so Hugh, I think, asked Mark whether he'd be kind enough to come up here, and at really quite short notice he's come to tell us about what his plans are and what his research is about. So thank you very much indeed, Mark, for coming. And we're kicking you off. We'll put you in the centre here for questions afterwards, and then we'll let you go.
Thanks very much. Thank you. So it's a great pleasure to be here. Thanks very much for the introduction. I was just actually from the last talk, I wasn't going to talk about how I got involved in this or interested in this area, but I thought it might be relevant. So I'm a neurologist and working in the field of movement disorders, largely people with Parkinson's disease and Tourette syndrome, things like that. And working in a specialist movement disorders clinic, about 20% of the people coming to those clinics had symptoms which didn't really fit into categories like Parkinson's disease and so on. And people didn't really know what was wrong with them. They might use those terrible words that should be banned from all textbooks, medically unexplained symptoms. And I got interested in what was wrong with those people. And predominantly models were either there's nothing wrong at all, or they're based on a particular interpretation of a Freudian model of how psychiatric conflict is converted into physical symptoms. And what I saw was just a lot of people who had very significant disability and no explanation for what was wrong. And my approach to that, which is a complex area of medicine, was just to try and think about mechanism and to concentrate on thinking about how symptoms might be being produced in the brain, and thinking that starting from that point is a much easier place to start from and a better place to start from than from a particular idea about why it might have happened. Because what we know about any medical condition really is that why things might happen is always very, very complex, and it's often different in different people, and it's often difficult to know. And in fact, most of our ways of explaining what's going on with medical problems and in treating them is about thinking about how the brain might go wrong for neurological conditions. So this took me into a way of thinking about neurological symptoms and medical symptoms in general, which sparked an interest in thinking about fatigue and chronic fatigue syndrome itself. So I want to talk to you about a project which is part of an MRC grant, which is based on that idea about thinking about mechanism, first of all. Think about mechanisms for key symptoms, and where maybe if we understand more about mechanism, then we'll be able to understand a little bit more about how we might treat people. So this is a collaborative project, and I just wanted to point that out, that it's not me on my own, and that there's a number of people involved in developing this idea, particularly Neil Harrison, who I think may have spoken at one of these events before. Neil is a neuropsychiatrist working at the University of Sussex, has particular interest in the interaction between the immune system and the brain. And James Kilner, who's a former colleague at UCL, who's interested in motor neuroscience, then the Department of Sports and Exercise Medicine down in Brighton, and also the Sussex ME Association, who have been particularly helpful in particularly with Neil, talking about this project and how we might get it off the ground. So this is the symptom we were thinking about when we were designing this project, about post-exertional malaise. So I haven't said post-exertional fatigue, because is something more than that, but it's a key symptom, as you all know, in CFS-ME, which encompasses a range of different phenomena, physical phenomena related to pain, and weakness and fatigue, also cognitive phenomena like cognitive slowing, fogginess, etc. And there's this interesting phenomenon that, at least for some people, that has a slightly delayed onset. So some people might have a period of exertion one day, and then the next day all of this hits in a very big way. So it's a key symptom, which is potentially a key mechanism of what's going on. So thinking about that symptom, are there any models out there from what we know about how the brain works in different conditions that might allow us to, a little bit more, to get more information about that? Well, there is a key model, and that's that this range of symptoms I've talked about, this post-exertional malaise, is similar to something which is usually called a sickness response. So a sickness response is a set of symptoms, which is similar to what I've just said, which occur in lots and lots of different species, so humans, but lots of different species, when they have an acute inflammatory response, when they have an acute infective response. So that seems like a reasonable model. So if we knew what was happening in this condition, in the sickness symptoms, is this something which is similar to what's happening in people with CFS? And importantly, this thing we just talked about, sickness response, is something where there's been quite a lot of work done, particularly by Neil Harrison, about looking at the network of brain structures which seems to generate these symptoms. So just to tell you a little bit about that, so I'm going to talk about studies which Neil did in healthy people, giving them typhoid vaccination. So when you have typhoid vaccination, it's a live vaccine, that gives people routinely a set of response, a sickness response, so a flu-like response. And what Neil did was give this typhoid vaccination to healthy people and then put them in a scanner and look at patterns of brain activation. And what you see routinely is activation in a particular brain structure which is called the insula, which is shown across all of these different scans using different imaging techniques. And the activation in this structure, the dorsal insula of the brain, seems to be related to how strongly people perceive these symptoms that are happening. And this is something where you can do further work in actually tracking a network of structures which seem to be involved. So taking information from the body and sending it up to the brain, and this structure, the insula, being particularly important in interpreting this information it's getting and generating the symptoms that people experience. And this is something called the interoceptive network. So it's a network of brain structures which let us take information from the body and let us interpret that and let us say what's going on in our own bodies. So there's some questions which come from this and sort of using that previous research. And one question is, what happens to these networks? So these networks which seem to be involved in acute inflammation and infective response and generating this whole group of physical symptoms, what happens to that network when people with CFS and ME are experiencing exacerbation of symptoms, so when they're experiencing post-exertional malaise? And there's a secondary question, which is whether the changes that people with CFS might get in this network in response to post-exertional malaise, are they the same as what people are getting when you give them an acute inflammatory challenge or acute infective challenge? Or maybe they're different. And those similarities and differences would be useful and interesting in understanding a little bit more about the mechanism for this important symptom. So this is a study which hasn't started yet, so I'm just going to tell you just briefly what the plan is. So we're going to get a group of people who have CFS and a group of healthy and age-matched controls, and we're also going to incorporate data from a number of studies that Neil's done in the past looking at people experiencing acute inflammation in response, say, to typhoid vaccination, and also actually a group of patients who have, for example, rheumatoid arthritis or hepatitis C, who have had immune challenges like with interferon and have developed chronic symptoms. So the plan is to do a baseline scan where people are in an fMRI scanner. We're going to use a technique which allows us to sort of map the activity in this network I was talking about, this interoceptive network. We're also going to take some blood samples looking at immune activation as well. And then we're going to do a specialised exercise protocol which is defined on the basis of their own person's heart rate and their own exercise abilities. So it's something where we're hoping that across people who might have a variety of different severities of symptoms, we can get people to do a similar amount of exertion. And then 24 hours later, we're going to come back again and we're going to repeat the study. So this is going to allow us to look at what the neural correlates are, what the patterns of brain activation are, particularly in these structures when people are experiencing symptoms after, so they're experiencing post-exertion malaise. We're also going to be able to look at different aspects of activation of the immune system by the blood samples that we're taking as well. So that is the plan for the study at the moment. And I'd just like to finish by saying thank you for the people who decided to study with me, and also obviously thank you to this research collaborative and to the MRC as well. Thank you very much.
So I think that what this illustrates, and we're going to see it in the next few talks as well, how important it is to study the complexities of a disease condition like ME, chronic fatigue syndrome, by using other disease models to help understand the complexity. And I think this is one of the great things the collaborative is encouraging now, is trying to suck people into the area who are in other areas, like you were, but then coming in and studying it using these new technologies to enable us to get a grasp on at least one component of a very complicated group of conditions. And I think this is very exciting. And the fact that the Neurosciences Board funded this, I mean, the competition would be incredibly high to get something like this through. I mean, you have no idea what you'd be competing against. It's amazing, and I think you deserve a lot of credit for doing that, because I know how hard it must have been to have got that support. Now, we do have some questions, because Mark is going to pop off back to Sussex. So, yes, look, lots of people are interested.
Back in 2010, the Department of Sports and Exercise Medicine at University of Brighton published a paper called Ammonia Metabolism, the Brain and Fatigue. Since then, there's been a paper by Lengert and Russell, who proposed a model of post-exertional malaise, which does fit the before and after studies carried out by Van Ness and numerous other groups. And this system, and it sort of agrees with what Julia Newton has found in the AMP-K, the fact that AMP-K is inhibited, and that is the change of AMP monophosphate, the adenosine monophosphate produced by the ADK reaction into inosine monophosphate with the release of ammonia. And ammonia has been found in a post-mortem of patients with Alzheimer's disease. So this is not a new idea. But the mathematical calculations of Lengler show that the post-exertional malaise can be produced by this process because it requires the resynthesis of ADP and ATP essentially from scratch, which takes several days.
Thank you.
Could you comment?
I'm not sure if I can comment in detail. I mean, I think that what you just said shows an important point is that I suppose I'm trying to take a slightly one step back view of saying, well, we have a symptom which is commonly reported, it's fairly consistently reported across a group of people. And we have a network of brain structures which we know are typically activated when people experience that symptom, but in the context of an acute infection or an acute inflammation. And so the interest for me is to see whether the pattern of activation which you get in those people having acute inflammation or infection, is that the same as what's happening in people with CFS? Because they're experiencing the same sort of thing, or is it something different? And it's possible to see whether the way in which that system activates might be different. and that might give you a better idea about mechanism. It also might give you a better idea that there might be different groups within people who have CFS-ME, and maybe they're going to respond in a different way. It's not going to tell you about ammonia in the brain, though, I'm afraid. But it's looking at it at a different level of description. So I think it's possible to. One important thing in this sort of research, I think, in complex conditions, is to look at lots of different levels of description. So you can look at things on a biochemical level. You can also look at the level of systems neurology, which is what this is, and you could look at the level of patient experience. You could look at the level of societal experience. But they're all valid, equally valid.
Thank you very much. That's very good. Yes, sir, please.
I see all your patients are doing the same order.
They're not. They're not. I should have said that there are some people who are going to have the exercise and scanning first, and then they're going to have afterwards.
So scanning can be quite apprehensive for some people.
Absolutely, yeah. No, it's something which is counterbalance.
Nearly got you, but not quite. But that's really good. Excellent, excellent. Just on the point, just going back to this, of course, with these new technologies, it'd be quite nice to sort of revisit some of the old ideas as well. It doesn't mean they were wrong, but it means that if we have another handle on the process, it might give insight into, connectivity between the metabolism, for example, that you were describing, and obviously the functional changes that you'll be measuring.
Well, actually, this is a new idea as far as CFS-ME is concerned.
Okay, in that case, two new ideas coming together then. We've got another question.
Yeah, can I just ask how you're planning to assess immune activation?
Yeah.
So that's something which, it's a very good question, but I would need to defer to somebody who's not here, who's Neil Harrison, who's a person who's going to be looking at that. I mean, Neil has a lot of experience in looking at cytokine activation, for example, in response to immune challenge. So there's a panel of tests that they would usually do as part of that.
We had a talk this morning that very much addressed some of that, and it'd be interesting to see whether you're sharing the same biological markers. One more, and then I think we'll let you go back to St George's.
Hello, I just had one question. I find it genius that you're testing people before and after exertion, but I was wondering, would you be testing, would you be performing the fMRI scans during mental exertion or not?
Yes, so the paradigm that's been used previously in neuroscience has been doing a Stroop task, which is a standard psychological or cognitive task where you have to look at words which might be a different colour from the. So there might be the word green, but it's coloured in blue, and you either have to tell what the colour is of the type or actually the word. So it's quite a difficult cognitive task. So it's so that's the way. That's what we use as the activation task within the scanner. We're doing that at somebody's baseline and in a situation where they've got post-exertional fatigue, and then it's looking at the difference.
Thank you.
Well, I think we wish you every success. We'd love to get you back again in a year or two with the answer. And we'll do that if that's all right, Grant. But thank you very much indeed for coming. Well, I'd now like to move on to another topic, which Esther Crawley is going to address. Now, Esther is a very special person, if anybody doesn't really know her, because firstly, she